Welcome in, everyone. I'm just giving it a couple of minutes just to make sure everyone is able to trickle in. We see that there's more in the waiting room. We're good to start. So good afternoon, everyone, and welcome to today's webinar, Chronic Traumatic Encephalopathy, a review of the state of the science. Thank you for joining us. My name is Kim Stranero, and I'm a community outreach specialist at the Brain Injury Alliance of New Jersey. The Alliance is a nonprofit organization with a mission to provide education, awareness, prevention strategies, advocacy, and support for those who have been impacted by brain injury. I would like to announce that we are hosting another webinar on June 16th on traumatic brain injury in service members and veterans. So please check out our website for more details about that. And we also have our annual walk scheduled. So please save the date for our Paramus Walk on September 27th, Mount Laurel on October 4th, and Bradley Beach on October 11th. And one more thing that we have coming up is our family camp. So this is our inaugural year. And it's a really wonderful opportunity for the whole family unit that's impacted by brain injury to come to camp with their family. It's a nice little getaway. So you can check out our website for more details about that too. And that's June 25th to 29th at Happiness is Camping in Hardwick Township. Now, just a few housekeeping notes before we begin the presentation. Attendees' microphones have been muted. So if you have any questions throughout today's webinar, please type them in the Q&A box. We will get to as many questions as possible at the end of the presentation. The webinar is being recorded and it will be available for viewing on the BIANJ website. At the end of the webinar, a link for a post-webinar survey will be placed in the chat. We value your feedback, so you are encouraged to complete the survey. You must complete the survey in order to receive a certificate of attendance. Once you complete the survey, you will automatically receive your certificate of attendance via email. So our presenter for today's webinar is Dr. Jennifer Russo. Jennifer Russo joined Kessler Institute for Rehabilitation as a brain injury medicine physiatrist in 2021. Dr. Russo is a graduate of Columbia University College of Physicians and Surgeons in New York City. She completed her residency in physical medicine and rehabilitation at Burke Rehabilitation Hospital in White Plains, New York, and went on to subspecialty training in brain injury medicine at Rusk Institute for Rehabilitation. She is currently serving as the Associate Program Director of the Brain Injury Medicine Fellowship for Kessler and Clinical Chief of Brain Injury Services. She sits on several national committees devoted to increasing the quality of rehabilitation medicine education and supporting new research endeavors. So I am so pleased to welcome Dr. Jennifer Russo.
Hi guys, thank you for having me. So we're going to talk today about chronic traumatic encephalopathy, or CTE. I'm going to start off, I'm just going to share my screen with you, and then we'll dig in. Okay. All right. So CTE, I think it's one of these things that really fascinates, us as an American public. And I think in large part, it's because of that, the association that we have of it with our American football players. It's really sort of become something that we want to know more about and worry about how it's popularized. And so there's actually been some interesting updates and sort of guidelines for CTE diagnosis, and then also sort of assessing a clinical syndrome that might go along with it. So we're going to go over this today. All right. To start, oh, do you see the Zoom bar in the middle here? I'll just move. There we go. Okay.
It looks like you're all good. Looks good on mine.
So no financial disclosures, tell you. And then our objectives for today are: one, we're going to discuss the history of chronic traumatic encephalopathy, or CTE. We'll talk about the pathophysiology. We're going to distinguish between the clinical entity and the histopathologically defined diagnosis. And then we're going to review the current diagnostic criteria for what's called traumatic encephalopathy syndrome, or TES, which is we'll talk more about, but it is the sort of clinical syndrome versus CTE, which is actually a pathologic diagnosis. And then we're going to talk about future directions for the study of CTE. All right, so chronic traumatic encephalopathy. So this is Dr. Harrison Stanford Martland, so at a different time in medicine, performing an autopsy while smoking. But he published a paper in the 1920s entitled Punch Drunk. He was actually serving as the medical examiner for New Jersey State, and he detailed sort of the history of 23 boxers, all who exhibited symptoms that we commonly associate with CTE, and then was able to match some of the clinical syndromes that he was seeing with these patients to the pathologic diagnosis. Prior to this, there had been some acknowledgement that that their repetitive head injury might be associated with changes on a gross sample of the sort of brain at autopsy, where they saw some hemorrhaging or bleeding in the areas between in the brain, small microhemorrhages. Yeah, this was sort of the first time that this idea of punch drunk, which was sort of colloquially out there, sort of was really acknowledged in the medical literature as a medical clinical entity, and tried to connect it to some pathology that he was seeing. He took very, very detailed histories of the 23 boxers, and he went so far as to discuss their aspects of the way that they box. So, apparently, and I don't know much about boxing, so forgive me, but depending on their sort of style, they were more subjected to different kind of hits and forces. So he was connecting both not only sort of what they saw clinically, what he was seeing pathologically, but also commenting as well on what sort of risk factors that one boxer might have over another based on how they play, and then if they're a second string boxer, that might be used a lot for practice where they're taking a lot of hits. So he really tried to dig into sort of the details of this punch drunk syndrome and brought it really into a sort of medical scientific community. From there, from Dr. Martlin's publication of Punch Drunk in 1928, 1937, J.L. Millspot, he was a naval officer. He retermed punch drunk. He felt like punch drunk was sort of not offensive, but sort of too colloquial and he came up with this more sort of scientific and medical term, dementia pugilistica. In 1957, quickly noted more of the chronic and progressive nature. So Dr. Martlin had talked a little bit about it, but really this was the first time that it was discussed sort of the longevity of the disorder. So he coined the chronic progressive traumatic encephalopathy as a proposed term to sort of describe the syndrome. In 1973, Crucelis et al. Published the first neuropathological study of 15 retired boxers in the light of this chronic progressive traumatic, where it really sort of we lost the thread of it, and then it really sort of came back into the public eye was in 2005. Amalu et al. Published a paper, and it was a case report where it described a retired NFL player who was found to have CTE, and so really that connection to our American football really sort of brought it back into the awareness more aggressively. And then in 2013, McKee et al. Published a clinical pathologic case series. So they looked at 68 men who had exposure to repetitive head impacts and discussed the pathology that they've done. So what are the biomechanics of head injury that might contribute to the development of CTE? So head injury is defined by traumatic brain injury. It's the disruption of normal function of the brain, can be caused by a bump, blow, or jolt to the head, or penetrating head trauma. Essentially, there's a lot of different versions of this. Was the CDC's definition, a lot of different definitions for traumatic brain injury. All of them involve a external force being applied to the brain, which can result in changes. You can have deformation of the skull and surrounding soft tissue, so fractures and hematomas, swelling of this bruising. You have displacement of the skull relative to the body, because the body and the baby accelerating, decelerating at different speeds. And then we're going to have deformation of the tissues of the brain. And that includes all the tissues of the brain, the blood vessels, the parenchyma, the neurons, the glial cells. So all parts of the brain become deformed during the application of these forces. A lot of what we know about the biomechanics of head impact actually comes from the car industry, which studies it pretty extensively, and then also sports such as football, hockey, boxing. And the mechanics of the forces that deform the brain in these settings are complicated. They're made up usually of a combination of what's called translational acceleration and rotational acceleration. different injuries and sports are getting different amounts of these. So translational is where, it's you move from here to here, and that's like if you think about the impact of a car, if you're hitting a head-on collision, that's a translational acceleration. You could also have rotational accelerations, which we see more commonly in boxing. Where again, the force is moved around this sort of central axis. Both of these will result in high levels of strain at what's called the fornix, the brainstem, and the midbrain specifically, and the corpus callosum, which is a tract that connects the two sides of the brain. So, as I said, when we think about the sports, there is a difference. Boxing tends to have higher rotational acceleration. You can see it in this picture where this hit is coming, how that force is hitting, versus football, which has a larger proportion of translational acceleration. And most of the research, again, because it comes from primarily car and then sports, football being heavily represented, we know more about the tolerance of translational forces than we do about rotational forces. This is just showing we don't have to dig deep into this image, but it was looking at a couple of different studies that looked at acceleration, peak acceleration forces, and just the peak rotational forces in different sports. And you can see again that boxing has a much higher amount of rotational force than football does, although football is not without it. And then there was only one study that looked at tolerance, so how much force resulted in the development of concussion, whether it was tolerated. When we think about how a force on a brain might affect a given person, there's characteristics of the patient that matter. So the age of the patient matters, the physical condition, and the size of the person all impact their ability to withstand externally applied force during injury to the brain. Again, most of this research is in men and adults. So there are some scaling techniques that they use to try to apply their understanding of the biomechanics to adult males, to females, and to children. But again, a lot of what we know about is male adults. All right, so let's talk about the pathophysiology of pathology of CTE. So I think before we dig, what I want to make clear, and we're going to say this a couple times throughout this talk, is that CTE is a diagnosis that is made at a histopathologic level. That means it is made after a patient has died and you have autopsy examination of the brain tissue. It is not a diagnosis that at this time we are able to give while a person is alive. So it really is based on what is seen in the brain tissue after death during that sort of autopsy examination. So what do we see? So in 2015, they put together a panel of neuropathologists, expert panel, and the goal was to create a consensus for CTE. There had been reports that had come out prior to this. The 2013 report by McKee was a large part of it, but this was a goal to sort of formalize the diagnosis, the pathology diagnosis of CTE. And what they defined this pathognomic lesion as an accumulation of abnormal hyperphosphorylated tau, which they call p-tau, in neurons and astroglia distributed around small blood vessels at the depths of cortical sulci in regular pattern. What does that mean? So tau, CTE is a tauopathy, and there are other tauopathies that we have, that are a part of neurodegenerative process. Alzheimer's disease, frontotemporal dementia, Lewy body dementia, they're all tauopathies, although the types of tau are maybe different, and then also the location and the way the tau is accumulated is different. And what is tau? It's a misfolded protein that cannot be cleared by the brain, so it builds up, creates these abnormal inclusions in the brain tissue. So we have these tau collections, these p-tau collections, that are specifically sort of centered around these little blood vessels, and then deep within the cortical sulci. We're going to see a couple of different pictures that show sort of where that sulci is. When we talk about the brain, if you think of the brain, we've got the ridges and then the dips in between the ridges. And so the sulci are those dips in between the ridges, and that's sort of where this is centered. As they become, we're going to talk about the classifications, it becomes more severe, you see more of it. And these are just pictures showing in the center of these pictures here, the sort of clearing area, that's those little blood vessels. So these are little blood vessels And you can see all around the accumulation of this tau. There's also a fair amount of inflammatory response around those areas too, those little blood vessels too. And so these are different sort of pictures of this collection of these. So in 2016, they got back together, the group, and met again. And they had two goals at this meeting. One was to further refine the criteria for diagnosis of CTE. And then secondly, they wanted to set a minimum criteria for diagnosis. So how much or how little tau do you have to see of these collections around the small vessels deep within the sulci for you to declare that this patient has CTE or would have had CTE, so they did a couple of things. So they updated, they updated the pathognomic lesion criteria just a little bit. So this was here. So they added on a few things, just these two. So we kept that it's a p-tau aggregate. We kept that it should be deep within a cortical sulci and around a small blood vessel. What we did add is that it couldn't be just on the superficial layers of the brain, but it had to be deeper. And the reason they did that is because they wanted to distinguish this tauopathy from some other types of tauopathy. There are other forms that they discuss that sort of cling to the superficial parts of the brain rather than the deep parts. And really the pattern that they are looking for with CTE is in the deeper layers of the cortex. Additionally, they came up with some supportive criteria that you don't have to have these supportive criteria, but they help lend credence to the diagnosis if you're seeing these other things as well. They're not, the reason they are not necessary criteria is because they're non-specific. They can show up in other things too. But if you see them in combination with what you're looking for, these pathognomic lesions, then you may have a diagnosis of CTE. And their minimum threshold was one single pathognomic lesion is enough to diagnose that sample, that patient, antecedent with CTE. I didn't highlight, but they talk about in both of these, they discuss the irregularity of the distribution of CTE, particularly early on. It has a predilection, which we'll talk about, to different parts of the brain, which are related to the way in which brain injury occurs most commonly. But it can be scattered, particularly early on. And then from there, we didn't talk about this is the rating systems. So after McKee, the original sort of publication, she had come up with the McKee rating system. So this is focused on the pathology. So it's looking at the slides, but it's identifying sort of the increasing load of disease. So from stage 1 to stage 4, with stage 1 being the earliest, the least amount of tau abnormal tau, to stage 4, which is much more widespread. So in stage 1, they sort of isolated lesions in the cortical sulci, and usually the frontal lobe is the initial spot. With stage 2, we start to see 3 or more of these lesions, and now we're seeing multiple regions involved, but we are sparing what's called the medial temporal lobe, which contains the amygdala, hippocampus, and entorhinal cortex, all of which are involved in behavioral regulation and memory and fear. Stage 3, now it's much more widespread. You're seeing it in multiple cortical regions, and we're involved in this medial temporal lobe, as we include the amygdala, hippocampus, and entorhinal cortex. And then finally, in stage 4, it's everywhere. They're finding p-tau pathology in the cerebral cortex throughout, medial temporal lobe, diencephalon, that's what's called the subcortical structures. Those are some deep parts of the brain that are important for all kinds of things, motor regulation, messaging. So there's a big relay station there for messages in and out of the body. So a lot of different things that happen through the diencephalon. The brainstem, which is important for our most basic functions, the cerebellum, which is important for coordination, and the spinal cord. So really diffuse in stage 4. Okay. So what happened when they did this second consensus in 2016 is they used smaller samples. So McKee really looked at everything in the brain. She's really many samples. So it's a very labor-intensive process to do what she did for the McKee rating system. When they did this consensus, they had neuropathologists look at a smaller sampling of areas of the brain, and what they found is they couldn't get with that smaller sampling. They could diagnose CTE and get a sense of how severe it was, but they couldn't really get as granular as stage 1 through 4. So they came up with a binary described as low CTE and high CTE. And essentially, low CTE is like 1 and 2 of the key, and 3 and 4 is sort of high CTE. And they designed it, they created a point system where if you see pathology in certain areas, it gets a point. If you have less than 5 points, you're low CTE, 5 or more points, then high CTE. And again, it also allowed, it in part allowed a smaller sampling for people going forward, because again, what was required for the key was very labor intensive. It's a little bit more accessible, and so they were also made it clear where you should sample, how much, and then this is just what they came up with for sort of the process of going through the designation of whether or not a sample has CTE and then how severe it is. So they're looking first for that pathognomic lesion. Is it present or absent? If it's pregnant, not pregnant. If it's present, it's diagnostic of CTE. And then these were the regions where you'll get your 1 through 5. It's from your 5 or more is here. So each of these they would click off if they found what these are called neurofibrillary tangles, which essentially is PTI aggregates in the different regions, low CTE versus high CTE. And this works, if it's absent, then you're trying to see if there's any other way to get them, essentially. And part of that is resampling, taking some more samples. If you still don't see it, then we can not CTE. And so from a gross pathology, so this is all looking under a microscope, what we've done so far. But there are some sort of gross pathology. When we say gross, just because we can see it with the naked eye, changes that are associated with CTE. These are non-diagnostic because they're not specific enough, but they're things that are sort of commonly seen. So advanced CTE. So what do we see? We see some cerebral atrophy, so that's thinning and decrease in size of the frontal temporal and medial temporal lobes. You might see thalamic and hypothalamic atrophy. When I talked about the diencephalon, these parts of that, shrinkage of the mammillary bodies, enlargement of the lateral and third ventricles. Those are the fluids-filled, CSF-filled spaces of the brain. The brain is a box and everything's in balance. So you have blood, brain parenchyma, which is the brain tissue itself, and CSF with the water component all in balance. So as the size of the brain tissue decreases through atrophy, those water spaces expand. So that's sort of where this comes from. And because you're sort of having it preferentially, you're having this loss of fullness in the front and the sides of the brain, that's the frontal and temporal lobes. The lateral third ventricles are the ones that are most impacted. They're the ones that get largest because, again, that's where the shrinkage is happening the most. You have thinning of the corpus callosum. This is a very important tract that connects one side to the other. You can have cavum septum pellucidum, often with fenestration, which means there's a septum that divides the ventricles. It can be damaged, it can be ripped, it can be bowed, so bent out of shape, one could say, for deformation. And then you can see also pallor of the substantia nigra and the locus coeruleus. These two are important areas where we make neurotransmitters. So substantia nigra is important for making dopamine, and locus coeruleus is important for making reckoning. So this is just that in picture form. So this was comparing, this is after autopsy. This is a patient about 10 years prior. So in the MRI here, we're already seeing some, at his age, in his 60s, we're seeing widening of these spaces, deep grooves here. These are deeper and bigger. This is bigger, and the septum is missing here. So it would be fenestrated. That is bigger. That's all the expansion of that lateral and third ventricle that we're seeing. This, if you looked at a young healthy brain or a brain of equivalent age without pathology, it would be fluffier. They can't describe it other than fluffier, fill more of the space, and you see less of this dark fluid-filled space. And you can really see it's schizophrenic, but these are the frontal lobes here, and these are the temporal lobes, and these are really puny compared to how they should be. This is the pathologic specimen at postmortem. This is showing this widened spaces here. This is all pretty thin, particularly here compared to what it should look like for his syndrome. So what's the clinical spectrum associated with the diagnosis of CTE? Again, CTE is not a clinical diagnosis. It is a diagnosis based on pathology postmortem. But there have been, for long, in this punctrunction of recognition of the clinical symptoms that go along with it. So where does it start? So it's a continuum, and it's progressive. So we start with some sort of mild decline of memory and executive functioning. So some small difficulties in cognition and episodic memory. It's followed by increasing mood and behavioral disturbances, and then eventually progression to dementia, where you have really reduction in both cognition and neurobehavioral control. Okay. This was again, this is from one of the key works, but it's kind of correlating what you might see from a symptom point of view to what stage you might be in. Again, it's not diagnostic, but this is just sort of observational information. So stage 1, where we have an early stage, can be asymptomatic, or you can have some non-specific symptoms, such as headache, lots of attention and concentration might be a little bit difficult, some depression or irritability. And these are non-specific symptoms, right? So these could be depression, anxiety. You could have. There's a lot of things that could be. This isn't clearly that this patient develops CPD. Stage 2, you can have more significant short-term memory deficits, see more aggressive tendencies, more difficulty with planning and organization, so a worsening of that executive dysfunction, and then more mood swings and some explosivity. So again, we're starting to get that neurobehavioral breakdown. Stage 3, we're getting worse. We might now have some visual spatial difficulties, some suicidal tendencies may come in, and our neurobehavioral regulation is worsening. And then stage 4, you're now seeing progression to dementia with profound impairment in cognition and manipulation. Again, not diagnostic, just an idea of the fact that this clinical syndrome that goes along with the CTE pathology is progressive, and it's progressive alterations in cognition and neurobehavioral control. All right, so what are the risk factors? Some risk factors we know about. So duration of American football play. Okay. So what do we know? What we know more than anything is that their duration of years played at a high level of play has a big impact in whether or not a patient is at risk of developing CTE. We're going to talk a little bit more about this, but what's going to come through here is that CTE is not only is it not a clinical diagnosis, but it is not a result of a single blow. So whereas we may have some overlapping syndromes, we've had a singular TBI. To get CTE, it's required many repetitive concussive and non-concussive head injuries, head impacts over a long period of time. So it's not enough to have CTE will not develop CTE from a single TBI, and even a couple TBIs. This is really repetitive exposure to this high level. And so why do we know that? So this was a study by Mez et al. Published in 2019 into 266 deceased American football players. And what they found is that more years of playing were associated with a higher risk of having CTE. There's an odds ratio of 1.3 for every year played. And it was correlated, the years played was also correlated with CTE severity. So not only were you more likely to develop CTE the longer you played, the longer you played, the more severe the CTE would be at the end. If you played less than 4.5 years, you were 1/10 as likely. So you were less likely to develop CTE. Whereas if you played greater than 14.5 years, you were 10 times as likely to develop CTE. So this 4.5 years becomes a break point, which you'll see when we talk about traumatic encephalopathy syndrome, the criteria there, that 5 years of play is considered to be the risk area. And it's not 5 years of play youth, and we're going to talk about that in a second. It's 5 years of play at a high school, collegiate, and professional level. That is the break point in which they sort of understand. For football, at least, that's where we do not have the same data there's some data coming out for hockey, where we don't have the same data for other things that might expose a patient to repetitive injury, including intimate partner violence, breaching, concussion, and explosive blast injury, concussive forces, and other contact sports. So this was just a picture form of the years played. So this is looking at duration of play, so how many years they played. And this is a binary, whether or not they have CTE. And this is the colors is a distribution of how many years. So these are this grouping of patients is less than 5 years, and then this bar graph in the middle then is showing you where the sort of mean and median and then is. So those who played in this area less than 10 years were less likely to have than the patients who had CTE had played longer, essentially, than the ones who did not. And then they looked also at the severity of CTE correlated to the duration of play. And then this is the distribution of the severity. So these are the number of patients with mild, these are the number with severe. And this mild CTE, again, played less years than the severe CTE. This is showing this at a different way of looking at it. So this is your odds of having CTE, yes or no, and this is your odds of having worsened, more severe CTE based on the duration of play. And then these two images down here are just showing this is the blood vessel, a normal blood vessel, and then this is a blood vessel with CTE. And then this E and F are looking at the severity. So E would be examples of mild. You see that staining deep in the sulci we talked about? That's mild CTE. And you see how it's irregular. It's not everywhere. Frontal lobe more than temporal lobe initially, and sparing that medial temporal lobe, which is towards the this medial side here, whereas F is more severe. It's much more diffuse throughout that entire area. Again, it's in those sulci, though. It's deep in those little cavern canyons. What we also do know, though, is that age at first exposure does not correlate to the development of CTE. So this is obviously important for sort of national policy considerations. Like, are we safe to expose our children to tackle football at a young age? So this was a study that indicated that the age of first exposure doesn't matter. It's really the years played at a high level of professionalism. So this was 4,189 former professional football players. They were dichotomized into age of first exposure, so before or after 12. And then they looked at outcomes. These were self-reported symptoms of depression, anxiety, perceived cognitive difficulties, and other sort of neurobehavioral regulation, and then self-reported health concerns as well, which were things like headache, sleep apnea, hypertension, memory loss, chronic pain, and others. What they found was that there was no association with the age at which a person was first exposed to football. It was really those years played at the higher level, not when they started young. That's important for us and helpful, I think, reassuring for many of us who are parents. And then one of the other risk factors they have identified, though, this is the ApoE E4 genotype. So the ApoE genotype is associated with the development of early onset Alzheimer's disease, where he's been found to have an increased risk of Alzheimer's. Now, Alzheimer's is also a tauopathy, although the tau is different, the difference in subtype, the different distribution of CTE. But so the question was, these people who have are genetically ApoE4, are they more at risk of developing CTE than others, which again would have stratification in life. And what they found was being ApoE4 positive did not mean we were going to get CTE. But if you got CTE and you were ApoE4 positive, your severity was worse. So the accumulation of disease happened faster than if you were not. But it didn't determine the yes, no, as far as will I get it, will I not. That was not shown. That it would guarantee, it's not going to guarantee that you get CTE, but it may suggest that somebody who gets CTE with this genetic type might have a sort of more precipitous or worse sort of outcome, more severe sort of form. Now, so what is the traumatic encephalopathy syndrome? So we've talked about some of the clinical manifestations. We've talked about the histopathologic diagnosis of CTE, but what researchers needed, at this point, we still have no way to diagnose CTE when a person is alive. And so what researchers needed is a way to sort of understand with the participants that they're looking at in prospective studies, the studies where the patients are still alive, what level of symptomatology they had, and come up with sort of a research diagnostic criteria for what they term traumatic encephalopathy syndrome. This is the syndrome now, the clinical syndrome that might be associated with CTE. This is not a diagnosis. Again, we do not have a way to diagnose people with CTE while they are alive. But this is meant to aid research to help understand the severity of the symptom burden of participants in studies that then will allow us to make some increased information about who might be more at risk. So this was a paper published by the National Institute of Neurological Disorders and the Stroke Consensus. This was published in 2021. It was a panel of 20 expert clinician scientists. They were convened, and their goal was to establish a research diagnostic criteria for traumatic encephalopathy syndrome. They went through what's called a Delphi procedure, where they sort of put out a set of diagnosis criteria, and then they anonymously voted and commented on it, and they keep doing those iterations until they get to a one that everyone agrees on, or that a certain proportion I agree. So what did they come up with? So this is what they came up with. This is the criteria that they came up with. So a diagnosis of TES, or traumatic encephalopathy syndrome, requires one, substantial exposure to repetitive head impacts from contact sports, military service, or other causes, which includes intimate partner violence. So substantial exposure, and they're going to clarify, we're going to look in a minute about what that means. 4 clinical features of cognitive impairment, episodic memory and executive functioning, and/or neurobehavioral dysregulation. 3, a progressive course. So we talked about how a single brain injury won't do it. And what I want to explain about how brain injury symptoms evolve over time versus how CTE symptoms develop over time. So if you think about everybody starts from birth to death with a certain amount of cognitive reserve. And as we age, there's a natural decline in the cognitive reserve for everybody. When you have a traumatic brain injury or a stroke or any kind of acquired brain injury, your reserve, rather than moving down this, you have a drop at the point of the injury. And then you resume the same sort of natural aging that you would. But you took that brain injury, took wherever you were, drops it down a bit, and then you continue along the same path as anybody else. So it doesn't accelerate the aging, it cuts into the total amount of cognitive reserve that you start with. What CTE does is, rather than declining, having your cognitive reserve reduce, it's sort of steady as anybody, it accelerates that. So if I'm moving like this and that's normal, they're moving like this. That's kind of an exaggeration, but it speeds up that process. That is not the case for single TBI. Single TBI drops the reserve, but then you continue with the same path. All right, so progressive course. Which is just to say that to diagnose traumatic encephalopathy, it does require that this is progressing for time and progressing immeasurably measurable time. And then finally, the clinical features are not fully accounted for by any other neurologic, psychiatric, or medical condition. So we kind of rule out everything else before you include this patient with TES. And then for those who do meet this criteria, they then, for this research purpose, they decide put a number grade on the functional level of functional dependence. So they're measuring how much this has impacted their life, and they from independent to severe. I'll show you in a second. Okay, so this is primary diagnostic criteria 1, so substantial exposure to repetitive head impacts. So this really makes clear that what they're looking for are really substantial exposure, repeated exposure to repetitive injury. So involvement in high exposure contact with collision sports, and it names all of them. So football, ice hockey, soccer, rugby, professional wrestling, MMA, other things like motocross or bull riding would be included. And then for American football, it's a minimum of 5 years of organized play required. This minimum should include greater than or equal to 2 years at the high school level or beyond. So really not youth sports. And the reason the 5 years won't talk about. So we know that for that one. We don't have the exposure risk thresholds for other contact sports, which is also what we mentioned. So again, looking for substantial greater than number of 5 years of play at a high level. Military service, again, we don't have exposure thresholds, but it have to be repeated exposures over time. Same thing, things like intimate partner violence would really the threshold for exposure for those. It's much harder for with women. It's totally different. So or not just women, I apologize. But we just don't have data. All right. And then for the core clinical features, so this is how you break down the cognitive impairment and the neurobehavioral dysregulation. It can't just be that I kind of think that my memory is off. It's one, it has to be a significant decline from baseline functioning. And then for this research diagnosis, they want it to be evaluated on formal testing to be shown to be there. And they're looking at a 1.5, but standard deviation below would be appropriate. So they're matching to age match norms. The neurobehavioral dysregulation, again, it has to be a change from baseline functioning. And then, the behaviors really represent poor regulation of control or control of motion. Emotions, again, is a progressive course. We don't really go this all too much. It can't be anything else. We got to rule out the other things. There are many things that can look like this. PTSD can look a lot like some of these: anxiety, depression, the Polish sort of, there's other things that might look like. And then finally, this is kind of the breakdown of the functional independence. So it goes from independent, subtle, mild functional limitation, still working outside the whole year, mild dementia, where you have some difficulty with instrumental ADLs, but you might need some cues for basic ADLs, but you mainly are able to do them. Moderate dementia, and really just simple chores, need help with basic ADLs as well, and then severe dementia is sitting really in here. And this is just another picture version of the stepwise process for the research diagnosis of TES. We start with the head exposure is okay, poor clinical features okay, not fully accounted for by other disorders okay, and then if 1, 2, and 3 are met, then they meet criteria for traumatic encephalopathy syndrome, and then you're going to determine the level. So it's a stepwise process that all the criteria need to be met prior to getting down to the diagnosis. And then this is sort of a rubric where for research purposes, again, it's not to be used for patients that who are seeing you clinically, but for research diagnosis, they then break it down into what would be suggestive of CTE, possible CTE, probable CTE. But again, there's no definitive diagnosis until it's a pathologic specimen postmortem and you confirm that it's definite CTE. Everything prior to that is just sort of levels of certainty based on which of the criteria they meet and to what extent they meet it. So it's breaking down how extensive they meet the criteria. And this is more research, it's really not a diagnosis. And so why is it not a diagnosis? And this is, I think, really important. So there's a study, this was a study in JAMA recently that looked at what happens when people perceive that they have CTE. Does it increase their risk of suicidality if they think they have CTE? This was specifically looking at former professional football players. There were 1,980 former American football players in the study who responded to the survey. 681 of those, which is a third of them, reported received CTE. They thought that they had CTE. What they were, things that were most associated with thinking that they had CTE were cognitive difficulty, low testosterone level, headache, concussion signs and symptoms accrued during playing years. So if they had multiple concussions, depressive, emotional, and behavioral dyscontrol symptoms, pain, and a younger age were all associated with them perceiving that they had CTE. And then of those 681, 171 of them reported suicidality. It's 25%, versus in those who did not, it was think that they had CTE, which was only 64, 1,299, 5% who had increased, they had reported suicidality. So when they only adjusted for are the risk factors for suicidality, men who thought that they had CTE remained 2 times as likely to report suicide. So it seems to be a risk factor. This thinking that you have CTE seems to be a risk factor, maybe an independent risk factor for suicide. So I think it's really, really important that we understand that CTE is not diagnosed while people are alive. That is a postmortem diagnosis only. Right now, we're still working on figuring out, who might be most at risk. So what are the future directions? There's a big study that diagnosed CTE. The title of this research project is Diagnostics, Imaging, and Genetics Network for Objective Study and Evaluation of Chronic Traumatic Encephalopathy Research Project. So this goal of this project is to collect data prospectively on living with and without exposure to we've had talk about that in a second, to better look at their drawing blood, CSF, they're taking images, specialized imaging, they're taking neurobehavioral examinations, their detailed medical history, exposure history, genetic information, demographics, to try to see what they can find out about who might be more at risk, and if there are any biomarkers that we can use in vivo when someone is alive in order to diagnose them with CTE. So what is it? It's an 8-year, it's a multi-center prospective study. They enrolled 236 male individuals, there's 240 with 4 got excluded, aged 45 to 75 years. They included 120 former professional American football players, 60 former American college football players, and then 56 men who did not have exposure to repetitive head injury. That's where they lost 4 because it turned out the 4 had exposure. And they collected all these different pieces of information. There's a ton of publications coming out in this group. Nothing is ready for prime time yet, but here's some of the biomarkers that they're looking for. So they're looking at CSF biomarkers, particularly markers for neuronal damage or neuroinflammation that might be associated with CTE. Serum biomarkers are some reports that tau may be elevated and acute in the blood in patients with acute TBI, although it's not unclear if that'll hold true for CTE chronic. They're looking at structural MRI. So we talked about that gross pathology before. So are there areas of the brain that shows specific amount of decrease that then you could say this patient has CTE? The problem so far right now is that it's, again, the findings are, there are findings, but they're not specific to CTE. So you can't directly say that that patient with these findings is necessarily CTE. Functional MRI, that looks at how the brain is functioning, with how the areas are working together, active area study. Diffusion tensor imaging is a modality that looks at the white matter tracks, which are sort of the axons that connect, I call them the highways connecting factories in the brain, which also are damaged in brain injury. So looking at those to see if there's changes there. MR spectroscopy, that focuses on metabolism of the brain, so the changes in metabolites, the way that things are metabolized that might be pathognomic for CTE. Susceptibility weighted imaging shows you where microbleeds were, so you can see where in the brain there have been old bleeds. It marks out hemosiderin, so what gets left over after some point. And so is there some amount of hemosiderin staining and type and distribution that might be associated with CTE? And then PET, they've used PET scanning to put tags on tau. So they essentially are able to light up the areas of the brain where tau has accumulated in. And they study, I didn't go into detail for it for you guys here, but that it was helpful in severe, it found to be helpful in severe, but not as helpful in sort of mild cases of CTE. And part of the reason is that the way that tau looks, so I had said that Alzheimer's and CTE have different forms of tau. As the disease progresses, you get more of a sort of Alzheimer's form that's more common and less of the sort of CTE kind. So the balance changes a little bit. And the way that the tag that they use, it did better with the sort of Alzheimer's type tau versus the sort of early tau. So it was, again, helpful in severe, but not so helpful in severe, which you want to learn early if somebody is at risk for CTE. So those are the sort of biomarkers that they're looking at right now. Again, there's nothing ready for prime time to say like this is, we can do it, we can diagnose it, but they're trying to put together sort of as much evidence as they can to kind of figure out how we might be able to diagnose people earlier before. Okay, so conclusion, CTE is a histopathologic diagnosis. It's characterized by abnormal tau deposits around small blood vessels deep in the cortical sulci with an irregular pattern. The clinical spectrum consists of progressive impairments in cognition and neurobehavioral control, which increase over time. The volume of exposure to RHI is the biggest risk factor that we know about for the development of CTE. And then traumatic encephalopathy syndrome is a research-defined clinical entity associated with CTE. Again, not a diagnosis in the clinic, and it's a diagnosis for research. And then work is being done now to identify in vivo biomarkers for CTE to facilitate post-mortem things. All right. So we can take questions and I have my references. But I'm going to stop sharing.
Thank you so much for that really informative presentation, Dr. Russo. I know I learned so much, and I'm sure everyone in the audience did as well. So we do have a few questions in the chat. It looks like someone asked, in the McKee rating system, are the stages similar to the progressive stages of Alzheimer's, starting with frontal lobe and then progressing to more areas of the brain?
Sort of, a little bit. The areas that are affected, Alzheimer's is a little bit more diffuse in general than CTE. CTE impacts that frontal and medial lobe first. And when we talk about brain injury, I didn't show a picture of the bottom of the skull, but the areas that are most impacted in brain injury are the inferior frontal lobe and the medial temporal lobe. And the reason that is that these areas, they're banging into bony structures. So you have soft tissue that's coming into contact with bony structures at the bottom of the skull and where the skull turns, sort of temporal and here. So those tend to be areas that just take a higher amount of forces anyway. So the pattern is specific to the way in which forces deform the brain, most commonly in brain injury. as it progresses, you get more of that medial temporal lobe, and then you get ultimately ending up in the sort of brainstem. And that area also has a high level of with rotational forces, particularly high level of shifting forces. So the distribution is different. Yes, the progression, like in general, the idea that you're progressively gathering pathology, which is associated with a worsened sort of clinical picture, is the case. But the particular pattern is very much based on the way in which the injuries occur.
Great. Thanks so much. And then kind of along the same lines, is there any way to slow the progression if someone does have traumatic encephalopathy syndrome or suspected, CTE? Is there any way to slow that progress?
Not that we know about yet. Again, there's those thresholds for exposure, which they are. Don't know how that's going to play into policy down the road, or how people will integrate that in their career choices or their career pathways. But the greater than 5 years, and then over 14 years for the football players to be really associated with very significant disease and a risk of disease. So besides stopping the exposure, there right now we don't know. The hope is that we will, but for now we don't.
Okay, understood. So then kind of along the same lines, there's not necessarily any like therapies or treatments that are recommended at this time if someone has suspected CTE or TES.
No, I mean it's going to be would be similar recommendations to other therapy, any cognitive impairment. So cognitive therapy can be very helpful both for development of compensatory strategies that can be effective for managing day-to-day life, as well as sort of recovery opportunities. They would things like you can have development of motor symptoms like Parkinsonism that would respond to sort of physical therapy. In general, we think that brain health is benefited by staying connected and staying active. And when I connect, I'm really connected not with people, amongst people, and connected to people. So I think maintaining an active and full life as best as possible is helpful. And then getting treatment for comorbid disease, like getting treatment for the neurobehavioral symptoms. So they do respond to the treatments that we would use for neurobehavioral disturbances related to depression or anxiety or anything. So, and that we use a single TBI requires treatment too. So getting treated can improve your ability to engage in the world, which can improve, but nothing targeted.
Thanks so much. Yeah, definitely made sense. And then someone's asked, what is known about the risk of CTE between male and female players in the same sport, for example, like soccer?
The samples are so heavily, these brain banks are so heavily male. There are active efforts to recruit female players to study prospectively, and then postmortem of it right now, where it's so heavily represented male. Even the studies that are related to like your risk of being harmed after getting a car accident are still heavily male. Like it's just males. So not enough, but hopefully more in the future.
Yeah, absolutely. Looking forward to future research, hopefully on on that topic. And someone else asked, does exposure in military settings include personnel in tanks as they fire ammo or being the operator of some of the big artillery launchers?
That's a really good question. They didn't specify, and I am ignorant to be what that feels like on your body. They talk a lot about like breachers, some people who their job is to break down the doors, being exposed. But I'm sure there are exposures in other settings too that are just less well accounted for. So again, it hasn't been specifically named out, but certainly if somebody they kind of leave it open in that the criteria is very specific about football players and how long, but it's less specific about military exposures because again, I think we just don't understand exactly what all would constitute a compressive force for military personnel. But again, any point at which there were many exposures, you might find at risk.
That makes sense. Okay, great. Thanks for that response. And then someone asked kind of along the same lines, do you know of any studies about CTE in members of the military, studies specifically due to a long use of guns, gun blasts? Do you have any studies you would recommend looking into related to the military?
No, don't there. That doesn't mean there aren't. There are. I just don't find anything off the top of my head.
Someone in the chat mentioned Dr. Pearl doing studies related to military gun blasts.
I'm sure there's like 100%. There are definitely studies focused on military. Just but
And if anyone else has any questions, please feel free to put them in the Q&A and I will address them.
it looks like there was a publication in the New England Journal of Medicine looking specifically at CTE in the brain of military personnel. Sorry, I should have. Well, I can only do so much in an hour, but yeah, it looks like there was a 2022 New England Journal of Medicine publication.
Okay, great. So that would be a good one to check out.
Yeah, for sure.
Awesome. Thanks for the recommendation. And let's see. Oh, just so everyone knows, the link for the survey is in the chat. And I had kind of, you kind of answered this in other ways, but is there anything else like a family can do if they have a loved one with suspected CTE, or can like that the individual can do? Where should they turn? What are next steps?
Oh, and so I think there are things that we know are protected. I think so. There's not a lot of evidence to true. There are studies that you could enroll in if you've had a lot of exposure that could be beneficial. But it's not necessarily studies that are going to help now more people in the future. What I would say is that there are certain risk factors for suicidality or suicide, and a lot of them have to do with connection and engagement. And so, what I would encourage if that family member who has a loved one who may be experiencing symptoms that could be associated with CTE to do is seek out services. So, the therapies that might be helpful to support them, see a behavioral specialist, consider medications that might be helpful to manage mood dysregulation, and then engage them as much as you can in activities they enjoy, life that is full, connected to family. I would say the things you can do to protect them from the focus on, do I have CTE and what's going to happen to me. What I say to my brain injury patients a lot is that none of us know what's going to happen to us. So we have this promise of a future that we all, have envisioned for ourselves. And the truth is, as human beings, things happen to us that we don't expect all the time for everybody. And so when you think, oh, I'm having some CTE, what the fear is, right? Is that you'll get worse over time, or that you'll die early, or that you'll degenerate. The truth is, you could walk out of them and get hit by a bus, like today. So like worrying about what might come in the future is not a useful endeavor, because you do not know at any point what that in the future is going to look like. So the best you can do is focus on the things that are worthwhile right now. Get out and do the things that are important to you. Be with the people who are important to you. Dig into those roles that you play in life, whether it's friend, lover, father, brother, all that. Yeah, focus on the future. There's no such thing, the fallacy for all of us, every single one of it. So put it out of your mind and deal with where you are right now. And make the best of where you are right now. And that includes getting the mental health services that might help them when you do them.
Absolutely. Thank you so much. That's great advice, I think, for everyone, to follow, to really embrace where they're at now and live in the moment and, follow their passions. Makes them happy. And it looks like a few people are saying the link in the chat is not working. Chris, are you able to update that link? Or otherwise, we will send it out after. So rest assured you will receive it. We just send it out via email with the follow-up email. But we'll see if we can fix that in the next minute or two. But I think that's it for all of the questions. And it looks like we're coming up on 1 p.m. and Chris just updated the survey link in the chat. So we should be all good to go. I really, really appreciate you presenting that for us, Dr. Russo. Thank you for sharing your expertise with us. If anyone's question was not answered today, you can email me at kmyers@bianj.org, and I will try to have our presenter answer it. One final reminder to please complete that survey. Chris updated it in the chat. You will automatically receive a certificate of attendance via email when you complete this survey. So thank you everyone for attending and for all of those really thoughtful questions and comments. And we hope to see you at the June 16th webinar. And that concludes today's webinar. Have a great day, everyone. Thanks again, Dr. Russo.
No problem.